Welcome to the Arterial Blood Gases Narrated lecture. The objectives of this narrated lecture are to be able to identify normal values on blood gases, understand the compensation of the metabolic and respiratory system function, identify basic conditions that can lead to acid-base dysfunction, identify and classify issues on the arterial blood gases, identify any physiotherapy issues, and identify oxygen-sensitive patients and suggest possible management strategies in relation to oxygen therapy and ventilation. But what are arterial blood gases? ABGs can form part of a respiratory assessment if clinically indicated. They help staff to assess how the respiratory and metabolic systems are working. Arterial blood gases are an invasive procedure which involves an arterial stab, usually to the radial artery. It is reported that patients rate this pain as on the BAS scale as 5 out of 10. Therefore, local anaesthetic should be used where possible. ABGs are usually carried out by medical or nursing staff. However, physiotherapists with an extended role are able to do this too. Why do we take ABGs? The BTS guidelines from 2008 recommend that ABGs are checked in the following situations. They should be checked in all critically ill patients. If a patient has unexpected or inappropriate hypoxemia, and that's given with an SpO2 of 94%, or any patient who's requiring oxygen to achieve this target range. Any patient who has deteriorating oxygen saturation or has increased breathlessness in a patient who has previously been stable with their hypoxemia. So this would be your patients with COPD. In any previously stable patient who has deteriorated and requires an increased oxygen requirements. Any patients who have risk factors for hypercapnic respiratory failure who develops acute breathlessness, deteriorating oxygen sats, or drowsiness, or displays any other symptoms of CO2 retention. Breathless patients who are thought to be at risk of metabolic conditions such as diabetic ketoacidosis or metabolic acidosis due to renal failure. Any patient who's acutely breathless or critically ill patients with poor peripheral circulation and they're unable to take a reliable pulse oximetry measurement. Any other evidence from the patient's medical condition that would indicate that blood gases would be useful to patient management. It is not routinely done for all patients in the respiratory ward. This slide shows the normal values for arterial blood gases. You may wish to pause this slide and take a note of them. In the UK, generally we report the measurement of blood gases in kilopascals. You may see in textbooks, however, some give the values in milligrams of mercury. This is more common in the USA. For the purposes of teaching and assessment here at GCU, we will use kilopascals. In textbooks, generally you will see pH used for the calculation of blood gases. However, clinically this can vary between sites due to the machines that they have. They may use pH or hydrogen ions depending where you are. In GCU, we will use pH, however, we will provide you with both values at all times. Our bodies use oxygen to generate energy. During metabolism, our cells use oxygen and produce carbon dioxide as a waste product. Arterial blood gases help us to assess the effectiveness of this gas exchange process in the blood. We do this by analysing the partial pressure of oxygen, which is abbreviated as PaO2, and of carbon dioxide, which is abbreviated as PaCO2. The partial pressure of a gas is a measure of the concentration of a gas within the mixture of other gases that are available. A little bit of chemistry revision now. You may remember from your high school chemistry that an acid is a substance that releases hydrogen ions when it is dissolved. Acids, therefore, will increase the hydrogen concentration of the solution, or they will lower the pH. A base is a substance that accepts the hydrogen ions from a solution. Therefore, a base will decrease the hydrogen concentration of the solution, or it will increase the pH. A buffer is a substance that can accept or release hydrogen ions depending on the surrounding concentration. A little bit more chemistry. The main equation involved in arterial blood gases can be seen below. Do not worry too much about this equation, it's just to help you understand the process that's going on within the body. What this equation shows is that if either the carbon dioxide or the carbonic acid are altered, then the hydrogen ions and then also the pH will be affected. When carbon dioxide is dissolved in the blood, it becomes acid. The more carbon dioxide there is in the blood, the more carbonic acid is generated. This dissociates and there are excess hydrogen ions which are then released. As mentioned before, the body strives to maintain homeostasis. The body strives to maintain your pH within normal values. If this doesn't happen, the buffer system within the body will try to compensate. The buffers within the body are either your respiratory system or your renal system. If one system is overwhelmed and there is a change in the blood pH, then the other system will compensate. The respiratory system is able to start compensating almost immediately, whereas the metabolic system can take days to compensate. Respiratory compensation, the lungs being used as a buffer. As stated before, carbon dioxide is a byproduct of cellular metabolism. In the lungs, excess carbon dioxide can combine with water and produce carbonic acid. The level of carbonic acid will alter the pH of the blood. The lungs are able to alter the rate and depth of respiration until the correct level of CO2 is achieved. The body does this by altering the rate and depth of your breath. This process occurs almost immediately. Metabolic compensation, the kidneys as a buffer. The kidneys excrete or retain bicarbonate if the pH decreases. The kidneys can retain carbonic acid if the pH increases, and the kidneys can excrete carbonic acid. The kidneys can alter the hydrogen ions by either adjusting the base secretion within the urine, altering the hydrogen ions secreted in the urine, or generating new carbonic acid within your blood plasma. This is a complicated process and takes days to occur. A side note on compensation. The respiratory problem will be compensated by the metabolic system, and a metabolic problem will be compensated by the respiratory system. The next slides will discuss the acid-base disorders that affect the body. These are respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Respiratory acidosis. Respiratory acidosis results from an increase in the carbon dioxide above 6 kilopascals and the pH less than 7.35. In most cases, this is caused by a decrease in ventilation, which leads to the inefficient secretion of carbon dioxide. Your patient may appear with some of the following symptoms. They may appear short of breath. They may be disorientated and suffering from acute confusion. They may report a headache, and the level of consciousness might be affected. The patient could be warm and flushed. They may also be sweaty. There is also an effect on the heart, therefore the patient may present as tachycardic. So there are a number of potential causes for respiratory acidosis. This is just a sample of them. They could result as a result of central nervous depression. This could be due to drug use, a trauma to the central nervous system, such as a stroke or a tumour. There could be spinal cord trauma above the level of C4, which innervates your diaphragm. They could have problems of poliomyelitis, or if the patient's had a heart attack and there's been some cerebral hypoxia as a result. There could be nerve or muscle disorder. There could be muscle fatigue or exhaustion, myasthenia gravis. If a patient has taken excess muscle relaxant drugs and are unable to breathe as well as they would have, motor neuron disease or Guillain-Barré syndrome. Disorders of the lung may also may cause respiratory acidosis. If someone has an acute exacerbation of COPD, if there's pulmonary edema, if the patient has ARDS, restrictive lung disease, if the patient is aspirated, which means that a fluid has been introduced into the lungs. This could be something that they have drank, or it could be vomit. If the patient has had a pneumothorax. Disorders of the chest wall. If there's been any trauma to the chest or the diaphragm, so that any problems with the diaphragm, including paralysis or splinting. Disorders of the airway. This could be an airway obstruction, or it could be severe bronchospasm, which might be seen in asthma. Respiratory alkalosis. Respiratory alkalosis results in a decrease to the carbon dioxide to below 4.5 kilopascals and has a pH of higher than 7.45. This is generally caused by an increase in ventilation. This leads to excess carbon dioxide, which is also known as hypocapnia. The patient might present with some of the following symptoms. They may report tingling in their fingers and feet. They may have numbness. They might have a cardiac arrhythmia. They could be sweaty or dizzy. Potential causes of respiratory alkalosis. Any condition that causes hyperventilation can result in respiratory alkalosis. This may include psychological responses such as severe anxiety or severe stress, even fear. Any unresolved pain, again, may result in respiratory alkalosis. Anything that may increase the metabolic demands of the body, such as fever, sepsis, or pregnancy, may also increase the likelihood of respiratory alkalosis. I have included some additional information in relation to some of these in the notes section of this slide. Moving on to metabolic problems. These are disorders where on the ABGs the metabolic system is the primary condition. Metabolic acidosis. Metabolic acidosis results when the bicarb is less than 22 millimoles and the pH is less than 7.35. It is either caused by an increase in the acid or a loss of bicarbonate within the body. The patient may present with some of the following symptoms. They may be very tired. They may be hyperventilating. However, with regards to hyperventilation, it must be noted that the respiratory system, as stated before, will start to compensate almost instantly, unless there is underlying respiratory pathology. The patient may appear very breathless. However, this is not a respiratory problem. The patient is trying to compensate for the increased metabolic demands. The patient may be confused. They may have a headache. The heart may not contract as well as it is capable of doing. They may be nausea or vomiting, and they may have low blood pressure. As stated in the previous slide, metabolic acidosis is either caused by too much acid or a loss of bicarbonate. Too much acid may be features such as renal failure, diabetic ketoacidosis, lactic acidosis, starvation, or an aspirin overdose. You will find a bit more information in the notes section underneath this slide. Loss of bicarbonate is through excess diarrhea. Moving on to metabolic alkalosis. Metabolic alkalosis results from the bicarb more than 26 millimoles and a pH higher than 7.45. This occurs as a consequence of a loss of hydrogen ions from the body or a gain in bicarbonate. Your patient may present with some of the following symptoms. They may have arrhythmias, confusion, seizures, dizziness, tingling, and decreased respiration. So again, a loss of acid may be caused by excess vomiting, increased use of diuretics, or if there's been gastric suction, which would mean that the acid has been removed from somebody's stomach. Or it could be from too much bicarb, so that's by taking too many antacids, so your anti-indigestion medication. We're now going to move on to how to analyse your ABGs. You may wish to get a pen and paper if you do not already have one. We are going to use pH, PaCO2, and HCO3 to help us determine what is the processes that are going on in the body. We will always provide you with the hydrogen ions within the university, and the oxygen is also will be provided to help you work out any respiratory failure. I am going to take you through a systematic approach to the analysis of ABGs. Systematic approach to the analysis of ABGs. The first thing you should look at is your oxygen level. As I said previously, oxygen is not directly involved in working out patients' ABGs. However, it is required to discover if your patient is hypoxic, which means that they're not getting enough oxygen. This can help us decide whether or not your patient needs extra oxygen to help them maintain their saturations. Normal oxygen is seen between 10 and 13.3. However, what we must remember is that patients who have chronic hypercapnia may be oxygen sensitive. You may wish to go back and revise hypoxic drive at this point. So, make a note of your patient's oxygen level. Is it within normal range? Is it high or is it low? Step 2. Look at the pH that you are provided with. The normal pH should be 7.35 to 7.45. Any values within this range are considered normal. A pH of less than 7.35 indicates an acidosis, whereas a 7.45 or more indicates alkalosis. However, a normal pH can indicate either that the gases are normal or that full compensation is going on. We will cover compensation in a minute. The next step is to assess whether the respiratory or metabolic system is involved. You need to look at both values and to see if they are either normal or out of range. If the partial pressure of carbon dioxide is out of normal range, but the bicarb value is normal, then it is a respiratory system that is involved. If, however, the bicarb is out of normal range and the partial pressure of carbon dioxide is normal, it's a metabolic problem. Now, just to complicate things, there is a possibility that they can both be off, and that is the next step. The next step is to assess compensation. There are different types of compensation. If in the previous slide one value was deranged and the other was within normal range, then it would be an uncompensated problem, and then you would know what the primary complaint was. There could be partial compensation, which means that the other system is starting to compensate for the original problem. You will know that if the pH is deranged, however, the two systems are also deranged. Therefore, all of your values will be out with your normal ranges. The body might have fully compensated for the problem. In that case, the pH will be normal. However, the two system values will be deranged. In which case, in order to discover if it is an acidosis or an alkalosis, we then set 7.4 as normal. Therefore, if it's less than 7.4, we consider it to be an acidosis. If it's greater than 7.4, it is considered to be an alkalosis. To discover a bit more about partial compensation, you need to discover what the primary problem is. In which case, look at the pH and the carbon dioxide values. If the pH moves in the opposite direction to the partial pressure of carbon dioxide, it is a respiratory problem. If the pH moves in the same direction as the carbon dioxide, it is a metabolic problem. With full compensation, once you have identified the direction of the pH using 7.4 as normal, you would then follow the steps above in the same manner to discover what the problem is. Now that may sound like a lot of steps. The next slide summarizes what is going on. So here is the systematic approach to ABGs. This is the summary here. You may wish to just pause this slide and take a moment to figure it out. The final step is to assess whether there is any element of respiratory failure present. Type 1 respiratory failure is present if there's hypoxemia, which is when the oxygen is less than 8 kilopascals. However, the carbon dioxide is normal. Typically is caused by a ventilation perfusion mismatch, and it can be acute or chronic. Type 2 respiratory failure is if there's hypoxemia with hypercapnia, so if the carbon dioxide is greater than 6. It is usually caused by impaired respiratory drive. Again, it can be acute or it can be chronic. We are now going to do a few examples. So let's put this all together. I'm going to work through the first example with you. There are then a few more examples on this page and on the next page. So let's have a look at the first one. Here are the values. What I like to do when working out ABGs is I like to put an arrow to indicate whether or not the value is normal or increased or decreased. So let's do that now. First thing you need to do is you need to look at the oxygen. Okay, so this patient's oxygen is 9, normal range is 10.6 to 13.3. Therefore, this is low and your patient is a bit hypoxic. You should make a note of this as your patient may require additional O2 if it continues to decrease or if they're symptomatic. So now let's look at the pH. The pH is 7.24. This is less than 7.35 and indicates that the patient is acidotic. So we know the patient is in acidosis, but let's decide what system is at work. As you can see, the PCO2 is altered and HCO3 is not. This would show that there is no compensation. As is the PCO2 that is raised, it can be therefore seen that this is a respiratory problem. Therefore, this patient has respiratory acidosis with no compensation. There is also no respiratory failure as the oxygen is greater than 8. So take a few moments and pause this slide and look at the next few figures. This patient is a little bit different to the previous one as they do have type 1 respiratory failure. This time, the carbon dioxide is less than 6, however, the oxygen is less than 8. Therefore, they have type 1 respiratory failure. So let's look at a patient who has compensation. Look at these values here and let's add in our arrows. Looking at the oxygen first of all, this value is 7, which is low. It's also less than 8, therefore your patient is hypoxic. Make a note of that. Now, when we look at our pH, it appears that the pH is normal. However, when you look at the other two values, you will see that they are both altered. This means that there's compensation going on as all values are deranged. What we do here is we then set the normal value for your pH at 7.4. This means in this patient's case that the pH is not normal, it is decreased, and therefore this patient is acidotic. But how do we know what system is involved as both other values are deranged? We look at the PCO2 and we want to decide whether or not it is moving in the same direction or the opposite direction to the pH. In this case, it is moving upwards as it is 6.5. This means that it is a respiratory component as the arrow is moving in the opposite direction to the pH. This therefore shows that this patient has fully compensated respiratory acidosis. As mentioned before, the oxygen is less than 8, and because this patient also has a PCO2 of more than 6, this patient therefore also has type 2 respiratory failure. So in summary, if your pH looks normal, but the other two values are altered, this is most likely going to be a fully compensated problem. Let's look at some more examples. Just another note about hydrogen ions. You may be on placement or work in an area which uses hydrogen ions rather than pH. This is particularly true if you are in Greater Clyde. You can, however, go through the same method as we have previously discussed by flipping the arrows that are there. So if we look at the first example that we looked at today, where the pH was 7.24, the hydrogen ions could be 54. As you notice, this is the reverse. Therefore, if you were given 54 as a value, your hydrogen ions would be increased. This would mean that your pH was decreased, and then you could go through the same process that we have previously discussed.